Good morning, everyone, and welcome to the 2020 Value-Based Healthcare Virtual Forum. And thank you very much for joining us today. For those people who have not met me, my name is Shannon Nott, and I'm the Rural Director of Medical Services for Western New South Wales Local Health District and the Clinical Director of the Virtual Care Accelerator for New South Wales Health. Today, before we begin, I'd like to acknowledge that today we're meeting on Aboriginal to pay my respects to elders past, present and future, and extend that respect to any Aboriginal or Torres Strait Islander people presenting here today or joining us virtually today. I hope that as we all go about our work in our respective LHDs and organisations, that we continue to take into account the needs of Aboriginal people across New South Wales. So today we've got a panel coming to you on virtual care. We've got four fantastic presenters who will be talking about various virtual care projects, and all of those really have been chosen because they exemplify the interaction of virtual care and the quadruple aim. And so certainly understanding the ability of virtual care to be able to improve experiences for people, families and carers, but also our clinical staff and clinicians, improving health outcomes overall, and also improving cost efficiency and having organisational benefit across New South Wales Health. I don't think that I need to dwell too much on the concept of virtual care, and I know that many people use the term virtual care and telehealth interchangeably these days, and we've moved to I suppose, around COVID, around utilising the term virtual care to be able to acknowledge a wide array of models of care that essentially allows patients and all members of their care team to be able to communicate to one another, be able to provide patient care utilising information technologies with the aim of facilitating and maximising the quality and effectiveness of patient care. And certainly the four case studies that we have today will exemplify that very much so. Many of you will know that in the construct of virtual care, there's multiple mechanisms to be able to provide patient care or interactions with patients or between providers or even support education and supervision. Telephone has been long-standing used across New South Wales Health and health services worldwide to be able to provide audio connection. We've moved into a realm, particularly during COVID, around the use of video conferencing. But there's multiple other modalities. The construct of store and forward or asynchronous transmission of being able to either transmit images, data, to be able to provide advice and management has been exemplified across the state, but also globally, and also quite an interest in regards to how do we look at new ways of managing patients outside of traditional clinical settings, and that's been done through remote monitoring. Patient's journey with virtual care, we obviously have a range of mechanisms in which a patient can be interact with the healthcare system. And I had the value of attending the bilateral regional health forum last week with both state and federal jurisdictions there. And there was a patient who spoke about this in regards to the care of his wife, and certainly being able to articulate that virtual care for him meant an array of different modalities. He spoke around store and forward for burn support for his wife when she was unwell with a degenerative condition. He spoke around video conferencing with surgeons, with speech pathologists, with physiotherapists, utilising real-time video in regards to managing her illness. Certainly, he discussed the role of face-to-face with nursing staff in his local community, but then also because of significant challenges being able to get doctors into his rural community, then discussed the role of video conference and discussion with himself, his wife, and the nursing staff around end-of-life discussions and end-of-life care. And certainly that patient story really exemplifies what this slide here today is trying to demonstrate. So today, for moving on to what we're here for, is some practical examples, and throughout the rest of the session today, I'll be introducing Anna Packer, Gordana Vasic, Rahul Gupta, and Rajini Jayaballa, who will be presenting their respective projects and the work that they're doing in their respective LHDs. So to start, I will hand over to Anna Packer, who's a clinical pharmacist as part of the virtual clinical pharmacy service in Western New South Wales and Far Western New South Wales local health districts. I'd like to welcome Anna for kicking off this panel session today. Anna.
Thanks very much, Shannon, and good morning, everyone. As Shannon said, my name's Anna. I'm one of the clinical pharmacists for the virtual clinical pharmacy service. And it's my pleasure to talk today about how we've improved value-based care by delivering clinical pharmacy services virtually. So our service was implemented in April 2020. And in comparison to some of the other presentations we might hear today, this service was not in response to COVID-19, but something that had been in planning well before. Today, I'm going to cover some of the data we have collected from the first 6 months of our service. So Western and Far West New South Wales comprise some of the most rural and remote areas in our state and cover approximately 450,000 square kilometres. Prior to the implementation of our service, we only had clinical pharmacists on site in 8 of 46 facilities, leaving a huge gap in the care of patients in rural and remote areas, but also a gap in the support of clinicians delivering care to these patients. Our aim is to deliver high quality clinical pharmacy services using telehealth and the electronic medication record. And this work is possible due to a translational research grant. We hope that through the evaluation of our service, we'll be able to demonstrate that clinical pharmacy services can, in fact, be delivered virtually. So one of the goals of our service is to empower patients through the provision of medicine information, so they are informed throughout their hospital admission. Prior to our service, patients received limited information about their medications, and we hope that we have been engaging with consumers and to deliver high quality pharmacy services using a two-way video and audio teleconferencing device. We are able to have discussions with patients and carers about their medications, both on admission and discharge, as well as throughout their admission, making sure they are informed about medication and are confident managing their own medications on discharge. Another role of our service is to ensure the safe and efficacious use of medications throughout a patient's hospital admission. By conducting patient interviews, we have been able to identify a number of medications that have been omitted. I can think of one circumstance where a patient was on a high-risk medication, and through a patient interview, we were able to establish this medication, communicate with the doctor, and significantly change the patient's hospital admission for the better. Our pharmacists have been working to improve the use of antimicrobials to ensure that the patients receive the best antibiotic for their infection and optimize their care. And there are many circumstances where the pharmacist has recommended VTE prophylaxis and thereby hope to prevent any unwanted circumstances of the patients developing a clot, stroke, or pulmonary embolism. Our work is not just beneficial for patients, but also for the wider healthcare team. Through the initiation of the virtual pharmacy service, we have been able to initiate 3 new multidisciplinary ward rounds, where I've been able to work with other clinicians and engage with patients during their admission. These ward rounds occur once or twice weekly, and with some clinicians on site and others also working virtually. And these have definitely enabled improved collaboration within the healthcare team. A big part of our job is to improve the experience for nursing and medical staff. And we have been able to provide medication education to over 70 nursing staff and have been able to work with doctors to optimise medication use throughout a patient's admission. It's been very positive to hear feedback from community pharmacists who often comment on how the service has improved the discharge process, especially at transitions of care, making their job much easier, which can only be beneficial for patients also. Each month we conduct monthly service rounding with hospital executive, where we cover the NSQHS standards. Standard 3, preventing and controlling healthcare associated infections, and Standard 4, medication safety. In these service roundings, we're able to improve the hospital's ability to meet accreditation standards. While today I've covered how we have hoped to improve the experience for patients, carers and clinicians, we also hope that we've delivered a cost-effective solution of delivering clinical pharmacy services to rural and remote areas, removing the barrier of a large geographical area and delivering a cost-effective service. And we also hope that through our service, we have improved the health outcomes for many of our patients. I'd like to finish with a quote from one of our patients who commented on how he had definitely had a better understanding of each of his medications and what they were used for. And he was very appreciative of the opportunity to speak with a pharmacist during his admission, something he hadn't had before. Thanks very much.
Thanks, Anna. And I'd like to remind people that we are using Slido today, and that should be in your information around how you might be able to ask the speakers questions. At the end, we will have a panel session, and certainly, Anna, thank you very much for that talk and review of the virtual clinical pharmacy service. It's certainly making a big difference in rural and remote areas across Western and Far Western New South Wales. I'll now hand over to Gordana Vasic, who's the Manager of Healthcare Interpreter Service for Western Sydney LHD, and we'll talk about how COVID accelerated video interpreting. Over to you, Gordana.
Thank you very much, Shannon. It's my privilege to present today and to showcase our success with video interpreting in Western Sydney LHD. I manage the healthcare interpreter service in Western Sydney, and it's only one of 5 healthcare interpreter services that exist in New South Wales Health. Our service is the largest metropolitan service. We cover 3.5 LHDs, and we provide more than 120,000 appointments per year. I'm just waiting for my slides to move. Okay, great. Here we are. So we are in the past, for the past 43 years, our service has been providing majority of services via face-to-face or on-site, which has been the gold standard form of interpreting service delivery for these 43 years. In 2005, we introduced phone interpreting as a cost-effective alternative, but it actually has never picked up. The reason why it hasn't picked up is because phone interpreting is not suitable for many clinical settings. And most importantly, it is lacking visual cues. For those of you who might be familiar with the NMHEC-RAP study, you will know that only 7% of communication are the words. 55% of communication is the body language and facial expressions. And that's why it explains why phone interpreting has never picked up. So video interpreting is the best alternative for face-to-face interpreting. And here you can see that before COVID, we had 89% of services delivered on site, 11% via the phone, and 0% via video. Things are changing fast, so now we are doing 6% of video interpreting, only 12% on site, and 82% via phone. Naturally, you will understand that because of the COVID crisis, we had to move to remote service delivery, so it's predominantly phone and video interpreting. You will see here our path from March till present. It started with a small pilot study at one of our busy women's health clinic at Blacktown, where we only had 17 video interpreting sessions in March. Then it started to pick up and we were getting more clinics on board. We plateaued around June and July, but then as we were onboarding more clinics and everyone is getting more interested in video interpreting, you can see the acceleration of video interpreting for the past 3 months. So how did we achieve this accelerated implementation? COVID definitely helped. What would have taken us 2 years in the past, it took us only 2 months now. And because our clinicians were used to face-to-face interpreting as the gold standard of interpreting, now the second best thing is video interpreting, and it is also COVID safe. The other important thing to mention is that Western Sydney LHD Healthcare Interpreter Service was an early adopter of My Virtual Care. In 2019, we started to test My Virtual Care, and when COVID hit, we were actually ready. So we also did lots of work in preparation in building our capacity. So we prepared and acquired appropriate equipment, and we also trained our significantly large workforce. We have 52 staff interpreters and 360 sessional interpreters. We managed to train 100 of those sessional interpreters already, plus all our staff. So basically, we also the other contributing factor for our success is the fact that we have had quite a few clinicians who've been champions for us, and you really can't do much without having clinicians as your champions. So there have been quadruple benefits of video interpreting and experience for both the patients, their families and carers, because they no longer need to travel to our hospitals, they no longer need to wait in our waiting rooms, and it's simply the convenience. It has also improved the experience for clinicians and interpreters, and I can tell you that our interpreters absolutely love it. It has also improved the overall health outcomes for CAL populations because we are now enablers for clinicians who can now deliver more care to patients at home and more timely care. And finally, about cost efficiency. We have made significant savings. So how did we make the savings? So in the past, while we were providing services on site, we had to cover significantly large geographical area. Therefore, travel associated cost was huge. With video interpreting, obviously there is no travel cost. So the savings that we are currently making in Western Sydney LHD is around $26,000 per month. You may think it's not significant, but if I say that we only provide 3.6% of the total service via video in Western Sydney, and remembering how fast we've been accelerating, it's very easy to see us in a few months' time delivering 10% of services via video and making $70,000 saving every month. And we hope that this acceleration will continue. And finally, the other benefit is that we have dropped our unmet appointment rate significantly during COVID because we are delivering services remotely. Unmet means that when there is a demand for interpreter, especially in the past for on-site, very often we were unable to secure interpreter to be available for on-site appointment. Now our interpreters are available for remote delivery of care much better than in the past. So that's my presentation. Thank you, everyone.
Thank you very much, Gordana. I think your overview of those interpreter services and certainly the rapid uptake is consistent with a lot of programs across the state. And I heard the other day from a clinician who was talking about how video has really improved the patient journey in regards to those interpreter services, particularly with those non-verbal cues that you've mentioned. So thank you very much for sharing. We'll move on to Dr. Rahul Gupta, who's the clinical lead for the Northern Mental Health Emergency Care Rural Access Program, or NMHEC-RAP program, who's going to talk a little bit about that program and benefits for patients across Hunter, New England. Rahul.
Thank you very much, Shannon. Good morning, everyone. And so I'm a psychiatrist and clinical lead for NMHEC-RAP Telepsychiatry Service. And along with Shannon, I also sit in the eHealth New South Wales virtual care and remote monitoring group. So NMHEC-RAP stands for Northern Mental Health Emergency Care Rural Access Program. It's a bit of a mouthful. And basically, this means that we provide telehealth assessments to rural and remote emergency departments, the clients presenting there with mental health issues. So as background to the service, so mental health presentations are not uncommon to the emergency departments. Many emergency departments see patients experiencing mental health crises. In rural and remote emergency department, there are additional challenges. There is limited access to mental health clinicians. They are distributed over vast distances. One clinician covering, say, 200 square kilometers. So they can't be present. And the staffing of the rural and remote emergency department is also, it fluctuates. They're often manned by locum staff and GPs. So the mental health expertise is very thin on the ground. And this results in, so when the consumer presents to the rural and remote emergency departments, they have to wait for somebody to come and do a mental health assessment. Sometimes for a smaller facility, they may have to be transferred to the nearest facility where mental health expertise is available. That sometimes is hundreds of kilometers away. On an average, it is 200 kilometers or 3 hours drive away. There are limited transport options, especially late afternoon in the evening. A consumer who needs further assessment will pretty much have to stay overnight for transfer the next day. And this results in the delay of care and often an exacerbation of the mental distress for the person. So NMHEC-RAP was established in August 2016. It is funded by the Ministry of Health. This was one of the recommendations of the New South Wales Mental Health Commission report, Living Well Strategic Plan, which was published in 2014. This is one of the 4 such services operating in New South Wales, and we cover the northern part of New South Wales. We are an inter-LHD district, so we are actually across, we are based in Hunter, New England, but we provide service to northern New South Wales and to mid-north coast as well. So our hub is based in Newcastle, where the clinicians do the assessment, and the spoke sites are the emergency departments, which are 30 at the moment, spread over 3 LHDs. We are a 24/7 service, and we see clients across all age ranges. Our youngest client just a few weeks ago was a 6-year-old child, and the oldest has been 86-year-old woman. It is a clinician-led service, so the mental health clinicians provide or do the bulk of the assessments, and they can consult with a psychiatrist or a registrar if required. There is a model of care which has a lot of detail to it about the processes we follow. We can do assessments under the Mental Health Act, basically meaning that if somebody has been brought to the emergency department as an involuntary person, in mental health terminology, it is called somebody who has been scheduled. We are able to see them, and sometimes we are actually able to assess them and determine whether they need to be further detained or they can be discharged from the emergency department. Some of this was already pre-existing, but because of COVID, the Mental Health Act has been expanded a bit, and we are able to do a little bit more under the Mental Health Act as compared to what we were doing previously. We have done about 1,450 assessments, and as a breakdown, about 25% of our clients are indigenous. We have got the male to female ratio is 45 to 55. The 15% of our clients are CAMS clients, which is child and adolescent. We see about 10% of the clients under the Mental Health Act, and we admit around 50% of those only. So we actually discharge 50% of those clients who are brought in involuntarily to the emergency department. Overall, we discharge about 2/3 of the patients we see via MEC-RAP, and we recommend admission to only about 1/3 of the patients we see. So this is actually quite a big and a complex service, and it's been a bit challenging to summarize it in 3 slides. There's a lot of detail to almost everything what I've mentioned briefly here. And just coming to the benefit, so there's a great amount of benefit to the clients. It is improvement in the access to the mental health care, waiting time in the emergency department. Many a times, family, friends who accompany the clients are able to join in the assessment, leading to more involvement of the patients and the family. And for the emergency department, it is reduced waiting time, reduced length of stay, and we hopefully bridge the gap between ED and the mental health service and the GP. And of course, for the population, there's a mental health care which is equitable and access to rural and remote areas. And for the health system, reduced need for transport and streamlining of the clinical pathways. Thank you very much.
Thank you very much, Rahul. And certainly MEC as a service across the state has been one of the most long-standing telehealth supports, particularly in rural and remote regions. And I think some of the outcomes that you've shown there are certainly replicated across the state and in other jurisdictions where telepsychiatry has been brought up. And psychiatry is a craft group or specialty itself is probably been one of the key leaders in progressing telehealth in the past and continues to do so. So thank you very much, Rahul. We might move on to Dr. Rajini Jayaballa, who's an endocrinologist from Western Sydney LHD as well, who's got a video talking about the Western Sydney Diabetes Virtual Care Program. We'll move across to Rajini's presentation.
Hello, I'm Rajini Jayaballa, endocrinologist at Western Sydney Diabetes. This presentation is on Western Sydney Diabetes Virtual Care, the successful establishment of a fully online diabetes service during COVID-19. We estimate that about 12% of adults in Western Sydney LHD have diabetes. We know that those with diabetes have double the risk of morbidity and mortality from COVID-19. In order to keep our patients and our team safe, we quickly pivoted to a full virtual care for hospital clinics and joint GP specialist case conferencing using the My Virtual Care platform. We performed a retrospective review to evaluate the success of virtual care from February to June 2020 and compared it to previous years. We found that despite the challenges the pandemic posed, we conducted over 80% occasions of service via telehealth than what we did previously. Cancellations and DNAs remained stable. Video links were largely successful, and most patients reported high levels of satisfaction. This slide outlines the stages of action establishing Western Sydney Diabetes Virtual Care. Stage 1 was moving all Western Sydney Diabetes clinics to telehealth. We included GPs and patients on the first visit. This allowed patients to either be with their GP or at their own home. It also allowed us to upskill GPs as what we did with our joint GP specialist case conferencing. We realized the importance of added admin support for telehealth to work smoothly and added a concierge service to onboard GPs and patients onto the service. Stage 2 involved adding digital solutions, including a Health to Sync app to record home BGLs by patients, and Flash CGM inserted with the help of our partner pharmacists. Online educational bundles and healthy living options PDF booklets we had previously created were used. These bundles have now been incorporated into the NADC Patient Education Resource Library. Stage 3 involves scaling up by promoting the service to GPs as well as holding virtual events. Stage 4 involved preparing the team to be able to deliver the service from wherever they were in order to survive any of the COVID-19 waves that were coming along. Stage 5 involved planning ahead to continue to redesign the service to adapt. Overall, Western Sydney Diabetes stood up virtual care, which is cutting edge, easy to use, comprehensive, and innovative. The added digital solutions enhance its impact. Together with University of Sydney, PwC, ACI, and Western Sydney LHD, we are sorting out funding and plan to do an in-depth evaluation, including an RCT of the service over a 2-year period, looking at the models of care of face-to-face, purely virtual, and hybrid approach. This implementation and evaluation certainly aligns with the quadruple aims of improving patient experience and outcomes, improving provider experience, and reducing cost of care. Thank you for listening. Hello, I'm Rajini.
Thank you there, Rajini, for that video presentation, and thank you to all of our speakers today for presenting. I will remind everybody that we are utilising Slido for questions today, and so if you go to Slido itself and use the code VBHC Forum 2, that code again is VBHC Forum 2, and you can enter your questions, and I can see a number of people have already put forward some questions today. So to start with for the panel, there's quite a few questions here around how do we communicate the changes and the benefits of virtual care to patients and communities. This has come up a few times, and some of you have started this. I might start with you, Rahul, given the time that MEC has run across Hunter, New England, across the state. How do you communicate the value of this type of program to patients?
Hi, Shannon. Thanks for the question. Look, MEC is more an inter-service collaboration, and the virtual care is actually between the primarily organized via the services. And what we do from our end is we actually, so when we were actually planning this service and we were rolling it out, we had a lot of orientation and meet and greet sessions with various services and with the emergency departments itself. So we didn't have any direct role in the promoting the service to the community, but we hope that since we have been in existence, that this is actually now well set, and all the spoke sites are very familiar with it, and including the patients who have used this service before.
Thanks, Rahul. And Anna, I suppose recognising that your program, the Clinical Pharmacy Service, is part of a translational research grant, and you've been capturing some patient experiences. Have you had any early lessons there or any early feedback?
Yeah, thank you very much, Shannon. We are very lucky that we have been capturing lots of patient feedback, the majority of which is very positive. So we started with lots of stakeholder engagement with our sites, who are fortunate to already have some pre-existing telehealth services. So it wasn't a huge change, but just incorporating another part of that into their service. And then I heard a really good explanation from one of our nursing staff who explained to a patient that in a metropolitan site, they might be seen in person by a pharmacist, but it wasn't cost effective to have one in every rural and remote site. So by delivering the care virtually, they were receiving the same care that the patients in another facility might get. And most patients are very open and appreciate that, the service of a pharmacist, which has been very well received.
And Rajini, I'll throw to you next. Given the diabetes care and the extensive nature of the program that you've described, was there patient engagement early on in, I suppose, the rollout of your virtual care program?
Yeah, thanks, Shannon. So when we first started, we quickly realized that we needed a bit more support to be able to onboard patients. There were a fair few patients, usually the older generation, that would be that were quite reluctant on coming on virtual care. Having the feeling that it's all going to be too complicated, or I can't do it, a telephone is much better. But when they were shown that it's quite easy, a lot of them came out quite positive, and they have continued using the platform. So it just taught us quite quickly that we needed that added admin support to hold patients' hands, to walk them through the platform. And once you use it, it's quite simple. And it was also a similar sort of experience even with general practitioners that we worked with. Many of them, we all needed to launch into virtual care quite quickly, and having that onboarding help really made a difference in having that positive outcome.
Thanks, Rajini. Moving on to the next question, I'll start with you, Gordana. One of the things that was evident during your presentation was certainly that video was deemed probably best practice beyond face-to-face for the non-verbal cues for interpreter services and so on. But some of your data showed that telephone was still the majority of interpreter services. How do we transition from telephone to video? Because that's been shown, even with some of the Medicare item numbers, telephone is still 80-90%, depending on the data you look at, the majority of this, where people generally agree that video is better in most circumstances. So how do you see us transitioning to utilising video a little bit more?
So that's going to be a gradual process, because we were forced to transition to phone interpreting almost overnight because of the COVID. We had to protect our workforce from exposure to clinical environments. So we started to deliver phone interpreting because that was the easiest one. But with video interpreting, you had to secure the equipment, to train everyone, to provide technical support, and also to provide technical support not just for our workforce, but also for those culled patients who had struggles from home to connect. So we had to work with the family members to enable that connection. Sometimes we had to support clinicians who haven't had earlier experience. So it's going to be a gradual process, but we are very positive that we can achieve in the near future transition probably up to 30%. The phone interpreting is currently necessity. It's not the best practice, and we are hoping that over the time, the best practice is on-site interpreting. The next best alternative is video interpreting. So we just need to build the capacity across the health system for video interpreting, and that means having up-to-date computers, having proper cameras and headphones for everyone, to create that environment in technical sense so that everyone can have access to video interpreting.
Thanks, Gordana. And for the remainder of the panel group, there was a question on a similar vein for your respective services. Do patients prefer telephone versus video, or are there differences or different circumstances where one would be utilised over the other? Perhaps I'll start with you, Rajini, and then go to Anna.
Yeah, so as I said before, that there's always going to be a small number of people who don't want to, come on board with the virtual care, and we have continued to use telephone with them, and it's not the best, and some even telephone is not ideal, and we had to see them face to face. But the vast majority, I would say at least 80% of people who we see are quite happy with my virtual care or a virtual platform. Again, just one of the main reasons being they've been shown how to use it. It's not a very difficult job, but there are a few buttons to click, and people can, especially people who are not used to having smartphones or using, the internet very much, they get overwhelmed with it. Sometimes I also have to add that we have utilized carers or family members to be the person who logs in for the patient, and we can do virtual care that way. And the other method that we've used, that I said in my presentation, is having the GPs there, so patients can go to their GPs and the GPs connect with us. And we've also had interpreters present in that sense, with the interpreter present on one side and the patient and the GP on the other, and us on here, and that's worked really well. So when it works really well, but there are a small proportion of people which, who just can't do it.
So I am being told that we will cut the feed at 10 o'clock. So I'll just throw one more question out, and if people can answer really quickly, what have been the most significant enablers for virtual care programs? Anna, perhaps let's start with you with virtual pharmacy.
Yeah, sure. So I think staff definitely on the ground have been a huge enabler of our service. Everybody has jumped on board and been really positive. We were talking about before the availability of telehealth, and we do 99% of our consults via telehealth, because we do have a two-way video conferencing device in each of our sites. So that's another big enabler, is having their technology already available on sites, and we don't have the barriers of outpatients or people who need assistance with using the technology, because all staff are familiar with how to use it. So that's definitely something that's been a really big enabler of our service.
Thanks, Anna. Recognising time, I want to thank everybody for and all our panellists for sharing their experience today. It's been a bit of a whirlwind review of 4 really important programs, and hopefully for those of you who've joined us today, today's session has been really valuable, and hopefully in the future we'll be able to share more great programs across New South Wales Health with you. Thanks everyone for your time.
Thanks, Shannon.
Thanks for the opportunity.